On this slide we can see skin. Staining is hematoxylinizing. Name of the slide is squamous cell carcinoma with keratinization. Generally, squamous cell cancer of the skin is a malignant tumor of epithelial origin which develops from keratinocytes, namely stratified epithelium cells in epidermis. Tumor cells tend to keratinization, which may vary and depends on the degree of tumor differentiation, which can be highly differentiated, moderately differentiated, and low differentiated. Due to the malignant nature of the tumor, it is difficult to say that this slide is a skin, but really it is. To low magnification, squamous cell carcinoma is characterized by the presence of proliferating cancer cells that deeply penetrate into dermis. We can see layers of squamous epithelium. These cells have eosinophilic cytoplasm and resemble spinous cells of epidermis due to their structure. Generally, these layers of squamous epithelium are surrounded with a dermis, so epithelium, that is tissue atipism, and epithelium penetrates the derma deeply. At high magnification, the tumor epithelial cells have a stratified arrangement. They are characterized by eosinophilic cytoplasm and signs of cellular atypia, which is the pleomorphism, means different size and shape, hyperchromic nuclei, increased nucleocytoplasmic ratio, increasing number of mitosis, and the presence of pathological mitosis. In some cases, between the tumor cells, we can see intracellular bridges, which look like narrow split-like spaces between the cells. Also, in the center of some cellular masses, which is very typical for well-differentiated squamous cell carcinoma, we can see so-called cancer pearls, which are rounded hyperkeratosis areas with some incomplete keratinization in the center. Also, the surrounding dermis contains some lymphohistiocytic infiltration, which is really a reflection of immune system response to the neoplastic process. Generally, considering the microscopic features of the malignant tumor, we can say that this tumor is well-differentiated squamous cell carcinoma. That is mainly due to the presence of cancer pearls. For squamous cell carcinoma with moderate differentiation, cancer pearls are not present, but cells still have the ability to synthesize keratin, as well as have a typical arrangement of layers due to the presence of intracellular contacts or intracellular bridges. Finally, in low differentiated cancer, intracellular bridges are completely lost, as well as the ability of cells to synthesize keratin. Exactly that is important to determine the prognosis and the patient management tactics. At this macro slide, we can see a lymph node. Staining is hematoxylinizing. Name of the slide is Metastasis of signet-cell cancer into a lymph node. Signet-cell or mucinous cancer can be regarded as a form of undifferentiated malignant epithelial neoplasm, in particular as the differentiated form of adenocarcinoma. The most common localization of such type of the tumor is stomach, or less frequently, this type of cancer can be found in the breast, gallbladder, pancreas, or some other organs. If we are talking about the stomach, according to the classification, signet-cell cancer of the stomach can be referred as diffuse type of cancer with predominantly endophytic growth and early lymphogenous metastasis. And exactly in this case, we can see metastasis of signet-cell cancer of the stomach into the regional lymph node. So looking on this slide at low magnification, we can see a lymph node which structure is almost completely disrupted with the presence of only few preserved lymphoid follicles. Normally there should be much more lymphoid follicles. Some of these lymphoid follicles are primary, some of them are secondary. At high magnification, almost all of the lymphoid tissue is substituted by masses of cells with signs of cellular atypism. Characteristic feature of this type of cancer is the accumulation of mucin in these cells, and this leads to displacement of nuclei to the peripheral part of the cells. So such cells look like a ring or signet ring shape, which gave the name to this pathology, signet cell carcinoma. To confirm the intracytoplasmic accumulation of mucin, a special staining method can be used, namely Alcyan blue staining. Given the aggressive, diffuse, and endophytic growth and early metastasis, prognosis of signet cell carcinoma is usually much worse than in adenocarcinomas. A portion of the liver is presented on this slide. Staining is hematoxylin and eosin. Name is Cavernous hemangioma. Hemangioma is a benign tumor of mesenchymal origin which develops from the blood vessels, in particular from the endothelium. According to the structure and morphological features, there are mainly two types of this tumor. One is capillary hemangioma and another is cavernous hemangioma. At low magnification, this histological slide of the liver has a heterogeneous structure, and we can see the liver tissue represented by the hepatocytes on one side with some evidences of degeneration, and from another side we can see a tumor, and this tumor is clearly delimited from the surrounding tissue of the liver by the fibrous capsule. At high magnification, tumor is formed by many thin-walled cavities lined with the endothelium and filled with the blood. Some features of cellular atypia are absent, indicating a benign tumor. Malignization of hemangiomas is very rare. However, the most frequent complications of such type of tumor are rupture of the tumor nodule with a subsequent development of hemorrhages. On this slide, we can see a part of uterus. Staining is hematoxylin and eosin. Name of this slide is Uterine leiomyosarcoma. Generally, leiomyosarcoma is a malignant tumor of mesenchymal origin of smooth muscle cells. According to the incidence, uterine leiomyosarcoma is 1 to 2% of all the malignant tumors of the uterus and usually occurs in women of 50 to 60 years old. In this case, also the probability of formation of leiomyosarcoma as a result of the malignant transformation of uterine leiomyoma, means the benign tumor, is extremely low. According to this slide, at low magnification, leiomyosarcoma is characterized by a lack of clear boundaries and infiltrative type of growth. We can see a hypercellular tumor site due to the large number of typical spindle-shaped cells that form a kind of beams. At high magnification, very pronounced cellular atypia should be noted, with a cellular and nuclear polymorphism, as well as, which is most important, with a large number of mitotically active dividing cells, which is one of the major diagnostic criteria of leiomyosarcoma. On this slide, we can see histological section of the portion of the skin. Staining is hematoxylinosin. Name of the slide is melanoma of the skin. Melanoma is highly aggressive malignant tumor of melanocytic origin with main localization in the skin. Morphologically, there are surface spreading, nodular, acrolentigenous, and lentigenous type of melanoma. Also, two phases of growth can be seen. The first phase of the horizontal growth and a phase of vertical growth. At low magnification, on this slide, clear distinguishable the epidermis layer, then the dermis layer, and finally the subcutaneous adipose tissue of the skin. The one of typical microscopic feature of melanoma is the invasion of atypical melanocytes deeply into the dermis. At high magnification, the melanocytes are characterized by the signs of cellular atypia. In particular, polymorphic cells have a large nucleus with a prominent nucleoli. Also, the mitotic figures can be seen. The cytoplasm of these cells is loaded of dark brown to black pigment named as a melanin. There is invasion of melanocytes into the epidermis as well into the underlying dermis. Also, the presence of lymphocytic infiltration is typical, and this reflects the immune response to the neoplastic process. At this slide, we can see a node which is most probably a part of peripheral nerve. Staining is hematoxylinosin. Name of the slide is Schwannoma. Also, a part of the clearly defined node, there are portions of muscular tissue, and therefore it is possible that tumor is located at the peripheral nerve somewhere on the limbs or any other somatic area. Schwannoma or neurolymphoma represents a benign tumor of neuroectodermal origin and is formed by the differentiated Schwann cells, namely cells that form the myelin layer outside the nerves. The most common localization of such tumor is peripheral nerves, particularly the eighth pair of cranial nerve, which is vestibulocochlear nerve. Microscopically, there is the outer connective tissue capsule or fibrous capsule, and the tumor node has a heterogeneous structure, including the hypercellular and more intensely stained areas, so-called antennae areas type A. As well as less intensely stained areas with less number of cellular elements, so-called antennae areas type B. At high magnification, hypercellular areas are composed of elongated cells with spindle-shaped nuclei without signs of cellular atypia, forming so-called verrucai bodies. Verrucai bodies consist of non-cellular center surrounded by the parallel rows of nuclei of tumor cells, so-called palisade structures. This tumor is benign, but some secondary changes such as necrosis and hemorrhages can be seen. As well as tumor may lead to compression of the peripheral nerves and the surrounding organs and tissues. On this slide, we can see a portion of the liver. Stain is hematoxylin. Name on this slide is liver in chronic lymphocytic leukemia. Chronic lymphocytic leukemia is a malignant clonal lymphoproliferative disease which is characterized by abnormal accumulation of mature B lymphocytes or B cells in bone marrow, blood, and also characterized by the appearance of so-called leukemic infiltrates in the parenchymal organs such as liver or spleen. At low magnification, we can see that the structure of the liver is not homogeneous and is characterized by the periportal infiltrates consisting of small cells, which is exactly leukemic infiltrates. At higher magnification, leukemic infiltrates consist of closely located lymphocytes of different level of maturation, but mostly differentiated lymphocytes. These cells are small cells with rounded basophilic nuclei and a narrow rim of cytoplasm. Against this background, pronounced degenerative changes in the hepatocytes can be seen, as manifested primarily by the accumulation of lipofuscin pigment in their cytoplasm. At this slide, we can see a histological section of a lymph node. Staining is hematoxylin and eosin. Name of the slide is Hodgkin's disease. Classical Hodgkin's lymphoma or Hodgkin's disease or lymphogranulomatosis is a monoclonal lymphoid tumor of B-cell origin, consisting of mononuclear Hodgkin cells and multinucleated Reed-Berezovsky-Steinberg cells, along with an infiltrate composed of variable composition of the cell population of small lymphocytes, macrophages, plasma cells, and other types of the cells. Like all lymphomas, Hodgkin's lymphoma is a malignant lymphoproliferative disease or tumor with primary lesions of lymph nodes. Also, four morphological types should be mentioned. The first is lymphoid predominance variant, then the mixed cellular variant, nodular sclerosis, and finally variant with lymphoid depletion. At low magnification, the structure of the lymph node is severely affected. In the cortex of the lymph node, there are almost no lymphoid follicles that should be present normally. At high magnification, The cell population is composed primarily of small lymphocytes. As well as single large Hodgkin cells that look like relatively large cells with a prominent large nucleus and a well-differentiated nucleoli. Also, we can see multinucleated cells known as Reed-Berezovsky-Sternberg cells, which are large binucleated cells with symmetrical or mirror-like bean-shaped nuclei with a prominent nucleoli. At this slide, we can see tissue of the mammary gland with a malignant epithelial tumor, means breast cancer. This slide has a special stain, demonstrating a widespread method in modern pathomorphology, namely immunohistochemistry staining method. In very easy terms, this method is based on the specific reaction between antibody and antigen, which can be nuclear, cytoplasmatic, or membrane. In case of positive staining, a reaction can be seen. In this case, that is the brown coloration, which can be quantified. From the viewpoint of immunohistochemical diagnostics of breast cancer, there are three basic receptors, or antigens, namely estrogen receptors, progesterone receptors, and finally so-called receptor of human epidermal growth factor, as in this case. Its abbreviated name is derived from the English name human epidermal growth factor receptor, abbreviated HER. On this slide, we can see a pronounced expression of the receptor on cytoplasmatic membranes of mammary epithelial cancer cells, shown as dark brown staining. So we can see the membrane staining of atypical epithelial cells. In contrast, there is negative immunohistochemical reaction in the stromal component in the malignant breast tumor. Detection of the expression of these receptors, including epidermal growth factor, is of great practical importance as it determines the prognosis and which is the most important tactics and the treatment of these patients. For example, in some cases, with a pronounced expression of this receptor on breast cancer cells, specific therapy with monoclonal antibodies such as Herceptin drug can be effectively used. Such therapy is known as a targeted therapy.